Well, hello, friends, and we are here for another installment of Kidney Talks with the George Washington University Ron and Joy Paul Kidney Center. I'm your host, Reverend Dr. Kendrick Curry of the Pennsylvania Avenue Baptist Church of Washington, D.C., and we have great co-hosts with Dr. Joseph Keith Melanson from the Ron and Joy Paul Kidney Center at George Washington University. And not with us today, but definitely part of us is Dr. Clive Callender of MOTEP, which is the Minority Organ Tissue Transplant Education Program. And we'll miss him today, but we have the venerable Dr. Melanson, who will always be available to ask some penetrating questions. Our guest today, being that this is Alcohol Awareness Month, will be Dr. Zahid Vahora. We welcome him. He is the medical director of the George Washington Liver Transplantation Program, and we are grateful to have him present for us today and engage in a wonderful discussion around alcohol awareness and liver transplantation.
Absolutely. Thank you.
Dr. Zahid, it's on you. Vahora, it's on you.
All right. All right. Thank you. Can I get my slides up, please? All right. Here we go. So thank you, everyone, for the opportunity. I'm going to talk about alcoholic liver disease during this Alcohol Awareness Month. Let's kind of go over some basic things that, a lot of us should know, and kind of going into kind of treatment and, of course, an introduction to liver transplantation with alcoholic liver disease. So, I'm a speaker with the drug company. Just want to kind of put that out there. So, like I said, we're going to go over defining what alcohol use disorder is, discuss the processes, progression of alcoholic liver disease, talk about outcomes and features of the disease and treatment, and of course, the role of liver transplantation. So really, alcoholic liver disease is really called alcoholic fatty liver disease because what happens when excess alcohol is consumed, it deposits fat into the liver, and that fat in turn causes inflammation in the liver. So really, it's alcoholic liver disease, but sometimes people may hear that they have a fatty liver, and that's related to alcohol. So I kind of want to make that clear. Really, we have to also talk about alcohol use disorder, which is the mental health disease that causes alcoholic liver disease. And I think that's the big thing, that this is a psychological or a brain disorder. And oftentimes, we hear, why can't someone just stop, or why can't anyone, just you could be stronger than this. But we understand this is a disease, and this disease, like any other, needs treatment. And this disease is categorized from mild, moderate to severe here. So this is something that really, we don't call it alcoholism or anymore. It's called alcohol use disorder, which is the actual disease that we're going to be talking about today. And so you can see here, because it is a disease, it has a very busy diagnostic criteria here, and really kind of what the big things that we kind of look at, as you can see through here, that with patients, it's really kind of measured within a year if alcohol is taken in larger amounts or longer periods than intended. And we'll talk about the amounts of alcohol later on in the presentation. But really, a lot of it comes down to like a desire of alcohol or unsuccessful efforts to kind of stop or cut down or control their alcohol use. A lot of their daily activities are spent with, using alcohol, talking about alcohol, or kind of recovering from that. When they have cravings of alcohol or recurrent use of alcohol that kind of interferes with the daily life, work, family, and things like that as well. And then, using it when situations are physically hazardous, such as drinking and driving, or going to work and drinking. So this kind of briefly, this is kind of what we look at when we say someone has alcohol use disorder, and things for people to kind of, as physicians and clinicians, kind of recognizing this in our patients, and for those folks out there who, recognize it in themselves or in their family members, and making sure that they get the treatment that they need for this. So kind of moving on more kind of clinically here, I want to kind of go over the natural history of alcoholic liver disease. As you said, most people, most of us were born with a normal liver, but as we end up drinking more alcohol, we'll talk a little bit about the amount of alcohol again, we start getting the steatosis, which is a fancy word of saying fat in the liver. And eventually that fat over time overwhelms the liver, and then you get a steatohepatitis, a fatty hepatitis from the fat. The fat now is causing inflammation in the liver. It's not just in the liver, but it's causing inflammation. That inflammation can lead to a type of scarring, which we call fibrosis, and that can lead to liver cirrhosis and liver cancer. So I know this is kind of a busy slide, but this is kind of what I want to talk about, the amount of alcohol that we're talking about. So people can drink and they have alcohol use disorder, but what are the risk factors that lead them from just drinking too much and flipping over to developing liver disease? So really, it's drinking above a threshold. And what is the threshold? So for women, it's 1 standard drink per day, and men, it's 2 standard drinks per day. So what is a standard drink? Now that's 14 grams of alcohol. And I don't think anyone ever measures alcohol based off the grams that they drink. So that's why I want to include this kind of cartoon right here, where it talks about a standard drink is a 12-ounce beer, 8 to 10 ounces of malt liquor or malt flavored drinks, 5 ounces of table wine, 3 to 4 ounces of kind of like those sherries or port wines. If you're having other liquors, it's like 2 to 3 ounces, 1.5 ounces of brandy or cognac, or 1.5 ounces of shots. So of gin, rum, tequila, whiskey, of that sort. So for women, it's really 1 of these drinks per day. For men, it's 2. So when you go past that threshold, you are running a risk of developing liver disease. And of course, the pattern of consumption, that daily drinking while fasting, and binge drinking also increases the risk of alcoholic liver disease. So some people don't have to be drinking every day, but if they consume more than the standard, that would kind of be spread out over a week or on the weekends or something like that, that can cause an issue as well. Of course, smoking cigarettes also increases that risk. The risk is higher in women than men, rather, because we know the women have a lower tolerance for this. Now, we know about 40 to 60% of liver disease, just alcohol use disorder is based on genetics. And the genetics we're talking about here are several things that we can't technically test right now. It's kind of just more research side of things, but these are genetic markers that people can have. Because I often get the question, Doc, I get it, I drink too much, but why I'm drinking with my buddies and why am I the only one with liver disease? Well, they are fine. Well, because we know that there is a genetic risk to this, and they may have other issues as well if they're smoking or if they have a greater body mass index, they're overweight or obese, and of course, that what we call comorbid condition, other liver diseases that are a problem, such as viral hepatitis B, and hepatitis C. And we know here in DC, DC has the highest rate of untreated hepatitis C in the country. So when someone has that and they're drinking above the threshold, they're going to develop liver disease at a faster rate or at a higher rate. And then metabolic disorder associated liver disease, that's a new term that we used to use for fatty liver disease or non-alcoholic steatohepatitis. We know when someone has that quote unquote fatty liver from non-alcohol, there really is no safe amount of alcohol. And we'll touch on that as well there. But I think the big thing here to take home here is this slide right here, and showing how much people really should be drinking to avoid, if they want to avoid liver disease. Now, however, the caveat is once they have liver disease, there's no safe amount of alcohol. So really going into like the epidemiology, like what's the prevalence? How much of this is out there in the world, in our country even? So we know the alcohol use disorder has the amount of people having alcohol use disorder has been rising before the pandemic. Just in like a decade from like 2001 to 2012, it's about a 49% increase. Now then we hit the pandemic, and you can see here, a lot more people were getting sicker. A lot more people were having alcoholic liver diseases. And there's a lot of postulations. A lot of people wondering, why did this happen and things like that. Well, we know that, this was a global traumatic event, COVID-19, the shutdowns and everything like that. So, that increased it. And therefore, with the increase of alcohol use, we saw about 24 to 27% increase in ICU admissions for what we call acute and chronic liver failure from alcohol. And about 57% of admissions were contributed by alcohol with patients with liver disease here. And the women had a higher rate of increases in alcohol admissions and deaths. And alcohol liver disease became the number one cause of liver transplantations from the pandemic and to this day right now that we're seeing right now. So, like we talked about, why did alcohol use disorder increase? Well, this was a massive traumatic event. And a lot of what we see in our patients with alcoholic liver disease is that, they have underlying depression or anxiety or stress. And that's where, this is a quote unquote legal drug that patients are using, our community is using to deal with this stuff, to self-medicate. Of course, with and we see a lot among the financial security, unemployment that kind of increased with COVID pandemic. We had a lot of psychological distress and isolation. And during the COVID pandemic, things like inpatient rehabs and even AA were kind of curtailed during that time. So it made it difficult for people to get treatment during COVID as well. So kind of going into this, and when I also talk about, over the years, yes, we understand COVID caused it, but even before COVID, there was an increase in alcohol use disorder. So what I really wanted to kind of show here, this is a slide that came actually before the pandemic, showing in the British Medical Journal about how the wine glass sizes have increased over the past 300 years. And this from 2017, even you can see this even if you go back and look at, old, Macy's catalogs or Sears catalogs of the wine glasses and over the years, this is the size. And so remember, we said now the average size is about 400 milliliters, which equals to 15.2 ounces. And remember, we said, 5 ounces is a standard daily drink for a woman. 10 is a standard daily drink for a man. So if you're doing a heavy pour and you're getting the glass all the way up to about here, you're already 3 times the standard daily dose of a woman. So that's why we're seeing it. Just culturally, our glass sizes have gotten bigger, and that is a problem, especially if you're filling it up all the way. So sometimes when we ask patients, how much wine are they drinking or how much are they drinking, they say, oh, I'm only having a glass. But what we find as physicians, we have to ask, okay, how big is the glass? Because they're filling it up all the way. They're already having too much. So like we talked about, there is this kind of contributing factor when people have quote unquote metabolic syndrome, either they have obesity, diabetes, high cholesterol, high blood pressure, heart disease, and stroke. That metabolic syndrome, that increases their risk of developing what we call metabolic syndrome associated steatic liver disease, that non-alcoholic fatty liver disease. But when you add alcohol to it, based off this Finnish study, the hospitalization, risk of liver cancer, and death continues to go up on these patients. So we know that when you have an underlying liver disease, or if you have risk factors of underlying, metabolic disorder, it increases your mortality, hospitalization, your chances of dying in hospitalization, and liver cancer. And what I wanted to kind of point out here, a lot of people say, well, doc, I'm having a glass of wine, yeah, I have, I have these other issues. You're telling me not to have any alcohol, but I know back in the day, the American Heart Association said, you can have a glass of wine that's good for your health. Now the interesting thing is, back in 2021, the American Heart Association dialed that back, and they said, the reduced risk of coronary artery disease based off that you get, the protective factor you get from alcohol, from a glass of wine, is offset, is that risk of heart disease. The higher the risk is the risk of cancer, liver disease, and other alcoholic liver related diseases and injuries. So they said, you know what, don't have that glass of wine. It's not there. Now, why did not that get that same amount of fanfare? Well, look when this was released in 2021. What was going on in 2021? We were in the midst of a global health pandemic, so it didn't get that fanfare that we kind of would have expected in the situation. So really, when it comes to alcohol use disorder, the important part is us as physicians, we need to be better about identifying this, preventing it, screening it, preventing it, and then treating it. So really, a lot of it is what we're doing right now, that public health messaging. And I know there's been in Europe, they've actually implemented in some countries higher taxation on alcohol, which has kind of caused, and we've been seeing it in studies, reduced alcohol consumption and lower alcoholic liver disease, especially in some of the Scandinavian countries, such as Norway. I know they implemented that as well, higher tax on it so that people drink less. And now with screening, I think the big thing is, these tools that we as physicians, we're not really using it as much. And there's some easy kind of evidence-based screening tools to talk to patients, to figure out if they to help screen them, see if they have these issues. And then once you determine that they have this disease, we know that treatment of alcohol use disorder reduces, liver complications, all-cause mortality, and so on and so forth. So we have treatments we're going to talk about here as well in the coming slides. One of the screening tools that we have that us as physicians will use for these patients is called the Audit C score. So this will really talk about, and it's similar to kind of the alcohol use disorder kind of criteria that I mentioned, but this, of course, this is a screening tool, so it's smaller, a little easier to use, and it asks simple things like, how often do you have a drink containing alcohol? How many units of alcohol are you drinking? And if depending on how much you have within a single occasion last year. And based off this, if the males have a score of 4 or greater, or females 3 or greater, that suggests alcohol use. And obviously, the higher the score, the higher the severity of the alcohol misuse there. So what can we do? Or let's say you're a patient and you're like, hey, Dr. Vahora, this is ringing true. I appreciate this talk, and maybe I have an issue with this. What can I reach out to my doctor for help with? So we know that there's many medications that can help with kind of the craving control, as you can see here. And I think if you feel like this is something that you need, you can easily talk to your primary doctor about different medications that we can use to help with the cravings and help with, when someone stops, help them from relapsing again. And there's a variety of medications that have been studied, some not studied, some are more anecdotal. But I mean, I use many of these medications to help keep my patients off of the alcohol if they have these risk factors. Other things that we use on tools in armamentarium is these alcoholic biomarkers. Now, especially when it comes to patients that we're perhaps evaluating for transplant, and like I said, I'll talk a little bit more about transplant here shortly. Us as physicians can use these tools to detect alcohol in a patient's system, either with a blood test, which will pick up alcohol within 1 month, or a urine test that can pick up alcohol within 3 days here. And I know a lot of rehabs and a lot of rehab centers, outpatient, inpatient, also use these tools as well to kind of help identify, not as more as I got you, but because we know this is a mental health disease, we know that there's a lot of shame and around drinking and not stopping drinking. This is more as a tool to kind of identify patients and get them the help that they need. So I wanted to kind of touch base a little bit before we kind of go into transplant, what we call acute on chronic liver failure. So this is a syndrome that's potentially reversible in patients with chronic liver disease. So they may have just some baseline liver disease, or they may even have what we call stage 4 end-stage liver disease cirrhosis. And then that's associated with multi-organ failures, that other organs fail, like kidneys, their lungs, their circulatory system, and whatnot. And we know that it's a very high 3-month chances of dying without treating this. So I want to kind of just put this here just as a kind of explain kind of the slides moving forward, especially as we kind of talk a little bit more about transplant as well. So going into that, we know that, we're talking about alcoholic, acute chronic liver failure, but what is alcoholic hepatitis? So alcoholic hepatitis, we know it's a major cause worldwide of this acute chronic liver failure. Remember, acute chronic liver failure has high chances of dying when people have this. So what is alcoholic hepatitis? Alcoholic hepatitis is when the alcohol poisons the liver cells to the point where they can't function. And so that causes extreme stress on the liver, and the liver just kind of loses some of this functionality. So this can occur as little as just during 6 months of heavy use of alcohol. And the heavy use here, we're talking about, before we're talking about the standard drink was one drink, but when people go to above that, 3 times that for women, 2 times their standard use for men, that they are at risk for developing alcoholic hepatitis. And these patients, like I said, because of the acute and chronic liver failure, can develop multi-system organ failure, kidney failure, neurologic failure, circulatory failure, and puts them at increased risk of dying, unfortunately. So we have certain tools that we can use to kind of treat alcoholic hepatitis. One of the main ones we use is a steroid called prednisolone. So for severe alcoholic hepatitis, you usually notice that the liver enzymes is one of the main things we look at, and that the AST, which is one of the liver enzymes, is more elevated than the ALT. And then we calculate certain scores that can help us determine how sick these patients are. And depending on how sick these patients are, then we start a steroid treatment to kind of help them with this process of kind of calming down the inflammation from the alcohol. Now, moving on to liver transplant, what are the reasons why, general reasons why the transplant patient? These patients either have cirrhosis, liver cancer, or acute liver failure, acute and chronic liver failure, you mentioned previously. We determine, where someone is on the list, and we kind of determine how sick someone is based off a score that we call the MELD score, and this stands for Model of End-Stage Liver Disease. Now, this score ranges from 40 being the highest, which is those patients are the sickest, to about 6 being the lowest. And we use this score because this score predicts, depending on where they are on the score, predicts what their chance of dying are at 3 months or 90 days. So when we evaluate a patient for transplant, we have the question we ask ourselves: is this patient sick enough to need a transplant, but not too sick where they can't survive a transplant? So what does that mean? We need to determine, hey, do they, we do a medical and a psychosocial evaluation. So that quote sickness, the medical sickness we look at, are, do they have any cancers outside their body that would prevent them from being transplanted? Do they have any heart disease, any kidney disease, any lung disease, or anything like that could make them high risk for transplant or increase their risk of dying just by going through a surgery, major surgery like a transplant? And the other sickness we look at is the psychosocial evaluation. We have our transplant social workers who are really experts in managing, identifying various substance abuse disorders and mental health diseases, to kind of evaluate, is there a mental health disease aspect to this patient that needs to be treated, or if there's anything that's too high risk for them to undergo a transplant. So like I said here, if we determine that they're a candidate, a patient with high MELD or liver cancer, we do a psychosocial and financial evaluation and a medical evaluation to determine if they're safe enough to undergo a transplant. And now, liver transplant, alcoholic liver disease, we know the patients once they have cirrhosis or alcoholic liver disease, and that MELD score gets above a 21, the studies show that these patients should be considered for liver transplantation. Now, we know based on these studies that, that's before they say 6 months sobriety, no fixed interval of absence. They don't have to be absent for a certain amount of time to do this. So we know that sometimes it can be carefully considered in patients who have more favorable aspects, even if they're not sober. And so what does that mean? I'm going to talk about here. So like I said, do patients need to be sober for 6 months? No, they do not. Because we found that sobriety for 6 months was actually a really poor predictor of them relapsing after transplant. Why was that the case? Because a lot of these patients were sober by accident. And what do I mean by that? They were sober because either, for past 6 months, they were in and out of the hospital, or, they had to move in with family because their sister or family moved in with them. So they weren't drinking. And, it didn't take into account anything but sobriety. It didn't take into account how sick they were or anything like that. It didn't take into account some of these lower things here, because the studies have shown what are better predictors of sobriety as opposed to time. The number one predictor was insight into their alcohol use disorder. The patient says, "Doc, I get it. I have a problem. And this is my problem." They get it. This is what caused my liver disease. I understand that. And that understanding is the key. Second, is family and social support. We often hear the term, it takes a village to raise a child. It takes a village to take care of a transplant patient, especially one with substance abuse disorder or alcohol use disorder. So they need that support there too. And of course, patients that do better predictor sobriety is that they don't have any other mental health disorders that would make it difficult for them to stay sober or get treatment for the alcohol use disorder after transplant or any other substance abuse disorders. They're not also doing lots of other drugs as well, because we often see sometimes these things, other drug use and other mental health disorder runs together with alcohol use disorder. That they have lack of legal or social or work repercussions from alcohol. And the best patients, a predictor is that, this is the first incident that led to it, led to transplant, or that, after the first incident, they completely stopped drinking after they were told by a physician, "Hey, you got to stop drinking. It's killing you." And they stopped then and there. A bad predictor is, yes, they kept drinking after they were told that they have liver disease. So I kind of want to go through a little bit of case here, and we can go across some questions. And this is kind of what we look at with our patients here. Oftentimes we see this. Let's say we have a 24-year-old female. She's got elevated liver enzymes. She comes to see us in the hospital. She comes in because she's a little yellow because her bilirubin's up. Her liver clotting ability, which is a function of liver, is a little impaired. Her and her liver enzymes are like AST is greater than her ALT. And she says, "Hey, doc, I don't drink that much. I just have one glass of wine." But yeah, of course, like I said, we ask her how big is that glass. If she's drinking this big a glass, it's going to be a problem. That's beyond that 5 ounces of wine that that's recommended for women. We get a biopsy, and you can see these little globules of fat. This is fat, these little spaces here. And that's what we see in patients with alcoholic liver disease. And we also see kind of these little, inside the liver cells, these little things that are called Mallory bodies. Decided by some guy, Mallory, he kind of named it himself here. But you kind of see this. This is what the biopsy would show in someone with alcoholic liver disease. So if you have that, you diagnose a patient with alcoholic hepatitis. So like I say, what are the scores that we use to evaluate the severity of patient's disease? The audit C, that's something to look at, not alcoholic hepatitis, but alcohol use disorder. That's a screening tool for alcohol use disorder. The Maddrey discriminant function is another tool. The FIV4 score looks at how much scarring if they have a liver, and this is one I just kind of made up on my own. So basically, the Maddrey discriminant function is what we use to diagnose if someone has significant alcoholic hepatitis. And if they have significant alcohol hepatitis, that's when you would start the steroids in these patients here. So just wanted to kind of say, that's kind of the end of my presentation, kind of going through with this. Does anyone have any questions or any comments regarding alcoholic liver disease or alcohol use disorder on this Alcohol Awareness Month?
The awesome presentation. I hope that this information will be continually viewed and reviewed. I would ask if you have fatty liver disease, is it reversible?
Yes. So any point. So liver disease is a bit of a spectrum. Like
Yes.
we're all born with a normal liver, which is stage 0. And then as that
Good.
insult occurs in the liver, you develop fibrosis or a type of scarring in the liver. For
Sure.
example, I tell patients, if I pull my pocket knife out of my pocket and cut myself in the hand, I'll get a scab, it'll bleed, I'll get a scab, it'll stop. But if I keep cutting myself there over and over again, week after week, I'm gonna end up with a nasty scar, right? Same idea, that insult that's repeatedly there on the liver can cause scarring. And the scarring progresses from stage 0, 1, 2, 3 to 4. Stage 4 is cirrhosis. That's a point of no return. That's why we call it end-stage liver disease. But any point before that, if you remove the insult, remove the alcohol, and that removes the inflammation, and that liver can recover. It's a slow process to recover, but it can recover and go back down to stage zero, which is normal.
When you say remove, what do you mean? Say more about remove alcohol. That means total abstinence, or what are you saying? That means going back to the 1 14 ounce that you talked about. Explain that some more.
Absolutely. So the studies show removing means abstinence,
Mhm.
because that you have to remove the inflammation, remove the source of inflammation to give your liver a chance to recover itself. Because if you're still having a little bit, it's you may not, you're just kind of like falling backwards. You're not able to kind of get that momentum to go through
I see.
and give your body a chance to clear. So the studies show if you have any underlying liver disease, there is no safe amount of alcohol.
Okay. That's an important statement that you just made. I hope that our listeners very much hear. Um, Someone in the chat said, they're from uh, Oneida, New York, and they've had a liver and kidney transplant in 2022. They've been sober for 2 years and did it by themselves, and they're 47. And I had the question with regard to this seems to know no age,
Yeah,
and many folk like Dr. Balanson and others had a great college years. You had fun during your college university years, me included, and I'm wondering what damage that could have done at the time when we were there, and
yeah.
then in the years since. So, what would you say to those college students that are binging, and the keggers and the other sorts of things that are going on?
Absolutely, absolutely. And like I had mentioned, binge drinking is just as bad as daily drinking, and we've seen it in the hospital here. We're at George Washington University. We've had college students come in with alcoholic hepatitis because they are drinking too much. And and also, I get the point where someone says, well, it doesn't happen to me. I did it. It was fine. There is that genetic component to it, which can affect it. And we don't have a way to test that genetic component, not commercially. A lot of that's still in that research phase of things, so you can see. But yeah, there is a genetic component, because and the genetic component comes out to be about 1 in 5 in the general population, about 20%. So, but we don't know which one it is. And I think the issue is you want to be careful, because it's kind of like playing Russian roulette. You don't know when you're going to get the bullet. You don't know if you're going to be the one getting the click.
Mm, mm.
But I wanted to say,
Wow.
Veronica, our the comment from the chat. Congratulations on being sober for 2 years. I know it's not a small feat, and everyone has their struggles, and that's the thing. We all, everyone has their difficulties, and this is a disease that knows no has doesn't discriminate based off age, gender, socioeconomic issues, and it is a disease indeed, and it is hard. So when you can work on yourself and beat it, that is a beautiful thing.
Wow, wow. Well, we invite our audience to put questions in the chat, whether you're on Facebook or YouTube, and we will get at your questions. Dr. Vahora is here and available to ask questions. Dr. Melanson, jump in here, um, and let's have some conversation. I know you're a kidney transplant guy. You got a liver transplant guy. What do you all talk about together, and if you're in conversation with one another?
No, thanks, Reverend. So, one of the things I wanted to get Dr. Vohora to talk about was the combination of alcohol and other things. So, like, I know that let's say you're taking Tylenol. Doesn't that combination of Tylenol and alcohol lower the threshold when you can get like a severe injury to your liver? Can you talk a little bit about that?
It's a great question. So Tylenol actually is pretty safe for the liver if you're taking the right amount of it, regardless of what you're drinking. The trouble that we get into with Tylenol is when people take too much all at once. So if you're just taking, you're getting headaches once a week, and you're taking, a 650 milligram Tylenol, and you may be drinking a little bit here and there, that's not going to cause a problem. But when if people are heavily drinking and they have alcoholic liver disease and they take beyond 2 grams or 2,000 milligrams of Tylenol at one time, that's when they're at risk of getting into trouble. If they're not drinking, that they should take no more than 3,000 to 4,000 milligrams of Tylenol. But like I said, that drinking does bring that tolerance of Tylenol down. So you shouldn't be taking too much of it, because then you're putting yourself up at risk for significant liver disease and possibly even liver failure.
Wow. Can I just follow up? Go ahead.
Yeah, I was gonna also ask, because I know we've seen this happen to patients that wind up getting liver transplant. I don't know if you had mentioned about the mushrooms and how these people can get into trouble. I'm not talking about mushrooms you buy in the store. I'm talking about mushrooms that people can find in their yard or out in the wilderness somewhere. And could you speak a little bit to how this should be avoided at all costs?
Absolutely. So, mushrooms, as we know, there's safe mushrooms you get from the grocery store, and then there's toxic ones. Most of the ones you're finding in your yard or on the sidewalk or anything like that are toxic. And, I can tell you from, I haven't seen it here since my over 2 years that I've been here. But I know in when I came from in Texas, there's a lot of people kind of going mushrooming and doing stuff like that. And we would get, like, I think every other year, one patient who ate mushrooms and they end up with a really toxic response and went into acute liver failure from eating toxic mushrooms, because they weren't looking at which mushrooms to get, or they weren't well versed. Yes, there are safe mushrooms out there in the community, but if you're in the city or elsewhere, there's no safe mushrooms for you to eat, because they definitely be very, very toxic.
Wow. As mushrooms, I do want to go back to this whole alcohol piece, and other drugs. You mentioned, the Tylenol comment up front. What about other NSAIDs? Because a lot of folk take that to deal with hangovers, right?
Yeah, absolutely.
Right.
Absolutely.
So they may drink, but then they'll take a Tylenol or ibuprofen or whatever else to deal with the headache prior to early morning. So say more about the difference between the Tylenol and the ibuprofen.
Gotcha.
And then let's talk about quantity they should take and should not take.
Gotcha. Absolutely. So Tylenol, like I said, if you have any kind of baseline liver disease, or you're drinking very heavily, you should not take more than 2,000 milligrams in 24 hours of Tylenol. That's when you run into danger with the Tylenol. In terms of the NSAIDs, and the NSAIDs are the ibuprofen, Motrin, naproxen. For those my friends from the South and Georgia and North Carolina, BC and Goody powders, those things, that the danger that you run into with those is that those can irritate the lining of the stomach and cause ulceration. You take too much of them chronically, then you run into issues. Then you have to see my friend Dr. Malance on here, because you end up with kidney problems. Because they can shut down the kidneys. So the issues with the NSAIDs, and especially if you're taking NSAIDs, you're drinking heavily, taking a lot of the NSAIDs, you get irritation of the GI tract, and you get either gastritis and ulcers, and they come in, and then at the extreme end, these patients come in because they're vomiting blood or they're bleeding from the ulcers, and we have to do an endoscopy on you and either treat the ulcer or put you on medication to kind of help that.
Mm.
Okay. Yeah, Zahid, let me ask you, going back to alcohol, is all alcohol created equal? People ask me, so in other words, if you're drinking beer versus wine versus whiskey, is it just really just the how many ounces of alcohol you're getting, or is there a difference in the way body sees alcohol, depending on what you're actually drinking?
Absolutely. Not all alcohol is created equal. And that's why I spent a lot of time on that one slide there, which showed, which drinks are, how much of each drink, you
Yeah.
know. So, a regular 12-ounce beer is one standard drink. So one beer, and one standard drink of a 12 ounce of beer, 5 ounces of table wine is one standard drink. 1.5 ounces of vodka or whiskey is one standard drink. So it depends on based off the alcohol level and the percentages and stuff like that too. So same thing, like if you're having malt liquor, no more than 8 to 10 ounces, which is one standard drink. So like I said, a standard drink is one of those for women, and two for men.
No, I understand, but is there a difference? Like if your standard alcohol is malt liquor versus if your standard alcohol is whiskey, does the liver see that any differently?
Yeah, because the amount of alcohol, the percentage of alcohol in each one of them is different, right?
Yeah.
So if you have, a whiskey, a 1.5 ounce, that little like glass of whiskey, that's about 40% alcohol, right? Malt liquor is what I think somewhere between 7 or 10% alcohol based off a 8 to 10 ounces or something like that. So it is different. The amount of alcohol you're getting in is more concentrated in that whiskey versus the malt liquor.
Yeah. Okay, so it's just about the percentage of alcohol.
Yeah, absolutely.
So understanding that alcohol is really a social lubricant, and it's sort of pervasive all throughout
our culture,
society, right? Our culture is part of a cultural norm.
Yeah.
What would you say to those that have difficulty resisting having a drink, and when they're in this social setting?
Yeah.
Because some folk feel a little bit pressured, so they'll get them just something.
Absolutely.
So
I've had this conversation just last week with a patient, actually two patients, and it's funny because like there was one guy who's like a blue collar guy, and he's going out afterwards, working at his mechanic shop out with his buddies, and another person who was an attorney, and saying, well, what do I say to these people when I'm out in these social situations? Because everyone does it. So, I think the for me, I think, and I've had other patients say this too, and I think I get where I kind of figure out what's the best thing to say is I even ask the patients who did stop, what worked for you? Yeah, you stopped, you what was the best situation? What was the best way to kind of tell these people? And what I've learned from talking to patients is honesty is the best policy. You tell them, hey, my doctor said I need to stop drinking because of my health. Just straight up say it. Don't need to say beat around the bush or anything like that. And I will tell you, for 9 times out of 10, friends, coworkers will understand that. Mm-hmm. And at 1 time out of 10, when they don't, that's probably people you shouldn't be hanging out with anyways. They're probably not the best influences for you, right?
That's
but most people understand that, hey, that's the situation. And saying that, and most patients, I say, hey, if they've said that to people, their friends are like, yeah, you know what? You're right. I probably should stop drinking too. It's probably right. My doctor didn't say it, but I know I'm drinking too much. I should probably cut back too. And then you have that influence to help others too by being brave and saying, hey, you know what? My doctor said this. I'm not going to hide behind the shame of it. I'm just going to say, you know what? I'm interested in my health. I want to live for my children. I want to live for my grandchildren. I want to live for my spouse. I want to do this. My doctor said it. That's why I'm doing it. And you'll be surprised at how many people will in that circle will say, you know what? You're right. I'm going to join you with this.
Yeah, and just to follow up on what Reverend Curry just asked, I've noticed, in social situations, how popular mocktails and alcohol-free drinks are becoming, and I think that people are starting to recognize that how much of a toll on your health alcohol can take. And so I do believe that there is this upsurgence in people trying to avoid alcohol Even, like you said, safe to have one drink a day. But I think that as people become more invested in trying to lose weight and decrease the fat intake, and understand that they feel better, that their brains are clearer, that thoughts are clearer without the alcohol, that you're having this upsurge. I know here in the DC area, there's this now popular lounge where it's all mocktails, no
Yeah.
alcohol whatsoever. And so I think that culturally it's definitely becoming much more acceptable to be avoiding alcohol.
Yeah, and I think that a lot of that comes down to really doing a lot of this outreach and people talking about alcohol
Yeah.
and the risks that it runs to our health in general. Like I said, I didn't touch much on this. I was touching more along the basis of liver disease with alcohol, but we know it increases the risk of head and neck cancers, colon cancer, gastric cancer, heart attack, stroke. All these other issues are increased by alcohol. So it really does, when I say increases all cause mortality, it increases all causes of death in a person.
Mhm. And I know it's not the subject this week, but I'll ask this question given that Dr. Calendar's not here. But one of the things, and alcohol is part of this, what even if you say, all right, well, there's a certain amount that's safe, and the same thing with marijuana, there's a certain amount that's safe. But the problem is, maybe not the old concept of the gateway drug, but Dr. Reverend Curry said this, it's a social lubricant. So
Yeah,
what can happen is it decreases your inhibitions, and then it allows other things to come in, right? And it's not that first drink, but it's the second drink. It's you do the marijuana. It's what does it lead to? We now know. I know in our field, we're seeing so many of these kids dying young because they're dying of drug overdoses, even though they may have been abusing drugs, but they were abusing something that should have been safe. But it's not safe because it's laced with these other drugs. And so I think this whole idea of having your cognitive function be at its highest level, because once those social lubricants are taken, it drops your inhibitions, and then you make bad decisions.
absolutely. And some of it's based on personality too. I often get the question, Dr. Vahora, do you do or do you do you drink? And I say no. It's like, oh, you must not drink because you're a liver specialist. I said yes, and or they're like, oh, you don't must not drink because you're Muslim. I was like, yes, but I also don't drink because I know myself. If I can't just have one Oreo, I would not be able to have just one drink either. So some people
I hear
have
you.
that, portion control issues and things like that. So when I think a lot of it is really recognizing yourself and having that introspection and be like, okay, well, I can't do this. And a lot of times just taking away, you're saying, can you just cut back or just have less? And sometimes what we see in someone, when we tell them you just cut back and have less, they go back down a little bit, and then they kind of they ramp up again because it's there, right?
Yeah, and I know that's true because I've been around you when they're like, let's say, chocolate chip cookies, and you're a beast. So I can only imagine if we were talking about margaritas.
Exactly. I like my cookies.
Now, he would do you like that. That's not. That's
Listen,
not.
man, he's been doing me like that all week, and as long as I've known him.
Well, one of the things, alcohol is basically sugar, right? It sort of metabolizes basically sugar. What would you say to those that they may not drink alcohol, but they drink a lot of soda and a lot of sweet drinks and a lot of other things? Can you speak to how that can do damage as well?
Absolutely. So you mentioned there's two ways to get fat into the liver. Okay, let me get my hands balanced here. There's alcohol, which causes because of the sugar intake causes that fat to kind of come in, and then there's what we used to call non-alcoholic fatty liver disease. We now call it metabolic disorder associated steatic liver disease, and that causes fat to kind of get into this. So people who have diabetes or pre-diabetes, or risk factors of obesity because they're having high carbohydrate, high sugary foods and things like that our body stores excess fat into the liver, and that itself can, even if you've never had an alcoholic drink, but you're not eating the healthiest. You're having a lot of high carbohydrates. You're having donuts for breakfast, pizza for lunch, and then pasta for dinner. That itself can cause excess. Our body stores that excess calories as fat in our liver, and that itself, we've seen patients develop cirrhosis just from that side of fat coming into the liver, that their liver failure from that. And we know reason why they changed from calling it fatty liver disease or non-alcoholic fatty liver disease to metabolic disorder associated was because if patients either if they have that level of fatty liver, they're at risk for developing heart attack, stroke, diabetes, high cholesterol, or if they have had heart attack, stroke, diabetes, high cholesterol, they're at risk for developing that liver disease as well.
Wow, that's some powerful information, and I think we need to talk about this. It shouldn't be just Alcohol Awareness Month, since alcohol is a social lubricant. We need to have this conversation as an ongoing part of community-based education, so
Absolutely.
that we can know what the facts are, and we have to make sure we are informed, and that's really something.
Well,
So
Reverend, just to that point, one of the things you should know is just up until the pandemic, fatty disease, or steatotic disease of the liver that Dr. Vahora was talking about, had become the number one reason to get liver transplants. So
is that right?
how we always talk about obesity as being one of the main causes of kidney disease.
Right.
Well, obesity had been the number one cause of liver disease. Now it's number two, behind alcohol, because alcohol surged during abuse surge during the pandemic. But those are the twin terrors. We talk about the trifecta for kidney disease is diabetes and high blood pressure and obesity. For liver disease, it's alcohol and obesity, right? So these things that are socially determined, we can change our own behaviors. We can impact this, but the education has to be there. People need to understand that what they do on a regular basis can so impact their own health. Most of what kills people is totally, completely under their own control.
And
Absolutely.
that's a powerful statement, because we talk so much about social determinants being 80+% of what a human being has to contend with versus the other maybe 20%. And we don't seem to realize that. So we need to pay very close attention to that. And you were going to say, Dr.
Yeah,
Vahora?
absolutely, Reverend. I think when I was down in Texas and practicing down there for about
That's
6
a
years.
great place, by the way. I'm a doctor.
So I had a pastor. That's one of these big churches. How there's the mega churches down there,
Yep,
and
yep.
he came to me and he had liver disease from non-alcoholic from a fatty liver, and he's like, once I moved down to Texas, I gained 30, 40 pounds. Everything's bigger in Texas.
Easy to do. Good food. Texas and Louisiana.
And the food's good, everything like that. And so what I kind of created this plan. I said, listen, you are the leader of your flock, and you do these healthy things. It's going to help everyone else. So I asked him, how many people in your church are overweight or have diabetes? He said, majority of them. So we said, is that, what, let's change this. And you have Bible study, you have this. What is it based on? Yeah, everyone brings like donuts or cookies or baked goods or pie, and we sit there, we do this. I was like, okay, so how can we change that? How can we change some of this healthy behavior? Because yes, some of your flock may have fatty liver, they don't know it, but you have it. So if we want to improve you, we can have that trickle down effect for everybody. So we said, instead of policy of this church, bring you healthy foods. No one's bringing baked goods anymore. You bring carrot sticks and bring this and that. Or what you do, I said, there's a park down the street from the church. Okay, well then what you're going to do? Everyone's going to park at the church, and we're going to walk a half a mile to the park and have Bible study there, and then walk back. And he's like, and then he reached out to his community. There was a dietitian in his church. He didn't know about it, so she gave a talk about diet and things like that. And as a community, they lost weight and got healthier and got their fatty liver, their diabetes, and everything else under control. So I think that's the benefit that you have by reaching out to the community like this to just have a healthier community, because like Dr. Malonzo said, these are controllable things. And it's always easier to do as a community together.
Yeah, without question, one of the reasons this idea even came up to have these kidney talks is because, my zip code and the next zip code has the highest incidence of kidney disease in this area, and it rivals that in the country.
Yeah.
And so we had to do something different in order to curb the tide of all of the debilitating diseases that we had over here. And so if the church is not going to do it, if the again, mosque is not going to do it, then we're in a serious situation here. So what we tried to do is offer healthy snacks, even when we do our ministry outreach activities. It does make folk upset a little bit that they
It
can't
does,
have
it does.
fried chicken all the time.
Yeah. Yeah.
But what we try to do is, everything from healthy eating, baked chicken rather than fried, more vegetables and less meat,
Yeah.
treating meat as almost sort of the garnish and the
Yeah.
vegetables as the main portion. Those sort of shifts. Um, but that it's a hard way to go. We've been working on this for a number of years, and we've lost a few pounds here and there,
Yeah.
but we need to lose so many more
Yeah.
so that we will remain healthy and live longer.
Absolutely. And it's not just it's about healthy living longer. People can live longer, but they're, you know, as Dr. Malone said, a lot of people stuck on dialysis or and things like that. That's not a real, I mean, that's not a fun way to live. If we
That's
could
not
prevent
life.
that,
That's not
that's not
life.
life. If we could prevent that, or if they're going through life with liver disease in and out of the hospital because their liver can't filter toxins out of their blood, their belly gets filled with fluid because they have liver failure. If we could prevent that. That's what we want to do. Because that we don't want the people just to survive, we want them to thrive.
Right. And one of the things, and Reverend just mentioned it, it all starts with the thought, right? So and that's where the education comes in, because then you get people to start thinking they want to be healthier. That's the first step.
Right.
Because once you start thinking it, once you bring it into motion, then people start recognizing how to become healthy. The other day, just to give you an example, the other day I was at a restaurant and I had cauliflower rice. Now, I'm from Louisiana, and that's something I had never had in my life, cauliflower rice. But it was good.
It is good.
And
It
the
is.
thing about it is, so it's as I am trying to be healthier, my mind is open to things that I've never tried before, if they're healthy, right? So more vegetables, more trying to drink more water. I tell my patients to drink water. I start every meal at the restaurant with a glass of water, right? So I want to drink more water. Dr. Vahora has had a good effect on me. I'm drinking much less alcohol than I ever did. I'm not totally without it, but I'm almost totally without alcohol. So you got to start with the thought. If you start with the thought, then it's going to influence the behavior, and then you're on your road. You're on your road to recovery. But this concept of I'm gonna take in all this sweet stuff, sweet sodas, desserts, fried foods. That's what's killing us. In the same way that we have too much violence in so many of these ethnic communities, we're eating in a violent way. And
Yeah.
both of those things need to change. That mindset of we need to be responsible for our own health and our own bodies.
Well, and
Absolutely.
without question, not only that, when are we going to declare the excess of sugar is like a drug, right?
It is.
It's like a drug. We eat this, even if you don't have the alcohol, you may go eat more candy
Yeah.
or more sodas or more other sweet things, and just to try to compensate. So
Yeah.
you're absolutely right. I will say that the comment you made about the cauliflower rice, that's amazing and awesome. What I think healthy eating will do for you is to help you begin to think through what eating options you have.
Yeah.
One of the things I love Indian food, and so I've eaten more Indian food and it's vegetarian options
Yeah.
that help me get through some of the other soul food options I may want to eat
Yeah.
more regularly.
Absolutely.
Exactly.
And
So
so one of it, I'm sorry. Go ahead.
go ahead, please, because we're
No,
gonna have to try to wrap it up.
absolutely. So, a lot of it, I mentioned, when kind of going back to kind of bridging what Dr. Melanson talked about, what I talked about with alcoholic liver disease being an indication for transplant. And the first thing I said is that these patients, why don't we wait 6 months for a lot of these patients is because if they have good insight into the disease. So that insight trickles, that applies overall. If you have insight into how, if you're not eating well, then you're going to go for the healthier option. So a lot of it is just really understanding and digesting the fact that, yes, I'm not eating healthy. Yes, I'm drinking too much. And then making that change. But first, you got to realize that you're not going to make that change, or that change is not going to last if you don't first come to that self-realization. Yes, this is a problem, right? Otherwise, you're never going to reach for that healthier cauliflower rice if you don't realize you have an issue that you need to fix.
Right.
That's it. That's it. Well, friends, I just hope you tell everyone that you know about this wonderful session during Alcohol Awareness Month. Dr. Zahid Vahora has shared some tremendous information that should be viewed not only just during this month, but throughout all of the year. He's given us a clinic. And if you go through and listen to the presentation and the slides and develop your own questions, if you have some, you can send them, and we will get back to you with appropriate answers. But this has been great. And I want to thank Dr. Melanson as well for just chiming in always as usual. And we are just so excited about these installments of the Kidney Talks with the George Washington University Ron and Joy Paul Kidney Center. Thank you so very much to all of our guests, and we look forward to seeing you at the next Kidney Talk installment. Take
Thank
care.
you for the opportunity.
Bye-bye.
Thank you. Bye.